A 37 years old gentleman named Mantosh Mandal, residing at Murshidabad, West Bengal, farmer by occupation, was done masters in Bengali language, belongs to upper middle class, according to modified BG plus classification, was admitted 2 days ago for elective procedure. Informants being the patient himself and his brother, reliability is fair. His chief complaints are breathlessness since 2 months, chest pain since 2 months, palpitations since 2 months, and fatigue since 2 months. Patient was apparently asymptomatic 2 months ago when he developed insidious onset exertional breathlessness since 2 months, which he first noticed while climbing 2 flights of stairs and when carrying when he was carrying weights and when he was walking for 1 kilometer on a level ground in the farm, suggestive of NYHA class 2, and which for which he consulted the local doctor who informed the patient about his existing heart condition which requires surgery and was started on oral medication which caused increase in frequency of mixed vision. He noticed only mild improvement of his symptoms on medication. Breathlessness remained static since 2 months, that is NYHA class 2. And he has history of dry cough during this breathlessness, which used to get relieved along with the breathlessness when taking rest for 10 to 15 minutes. No history of any positional variation in breathlessness, which is suggestive of paroxysmal nocturnal dyspnea or orthopnea. No history of these associated breathlessness. He has history of exertional palpitations since 2 months, suggestive of NYHA class 2, which was gradually in onset and gradually in offset, which relieves with rest. No history of such episodes present at rest or during night. No history of associated giddiness and pre-syncope during these palpitations. History of exertional chest pain since 2 months, which is suggestive of NYHA class 2, which was predominantly retrosternal, radiating to the back, relieved with rest. No history of associated sweatings, no history of any symptoms. History of yes, sir, angina. Yes, sir. He is having a retrosternal, which is only exertional, sir. And yes, sir. Radiating to the back is not a typical case. Interscapular area.
That also
Yes. In 6 angina is active chest pain because of the dissection of the ascending aorta, predominantly ascending and yes, sir, ascending and arch of the aorta, predominantly.
Which group is descending aorta, descending or dissection aorta? Which group?
Descending aorta. So predominantly atherosclerotic diseases. It can be because of the
age group.
Young patients.
Young patients. Ascending aorta. What is the aortic dissection before 40 years age? What are the causes?
So dissection can be because of inherited connective tissue disorders like Marfan's, Ehlers-Danlos, Lewis-Dietz, and uncontrolled hypertension. It can be because of
uncontrolled hypertension not below 40 years. There is no term uncontrolled hypertension.
Yes.
I thought it was
yes. Resistant hypertension, sir, and
no resistant hypertension.
Yes, sir, hypertension.
That is not below 40.
Yes, sir.
Most common descending aorta.
Yes, sir. It can be associated with congenital disease like bicuspid AV1, which is lead to aortopathy, and congenital chromosomal anomaly. Turners can be associated with rarely inflammatory aortopathies like Takayasu can also have aneurysms as well as dissections, and those who are having atherosclerotic risk factors which will cause atherosclerotic aneurysms followed by dissection. And traumatic dissection because of the deceleration injuries.
That is also descending aorta. Descending aorta.
Yes.
Isthmus and down.
Isthmus. History of fatigue, suggestion of NYHA class 2 since 2 months, which was exertional. No history of swelling of feet, abdominal distension, no history of hemoptysis, no history of lymph claudication, no history of
any positive history there?
negative history.
No, not that. So from history, what is diagnosis?
Sir, history.
What criteria will you use to differentiate? See, now there's a change, no, they never said, formerly it was called typical angina, typical angina, and now cardiac. Now there is no atypical, they have removed it.
Yes, sir.
Isn't it?
Yes.
Only typical angina and cardiac.
Cardiac,
So
not
what criteria will you use?
So based on three features, which is a typical character in the form of squeezing heaviness and typical area, site of the chest pain, that is retrosternal, and radiation to the medial side of the arm, left arm, till the jaws.
Features have three.
Yes, sir.
You are P precipitating factor.
Yes, sir. Increased with exertion.
Quality of pain. R is relief. So this we added two more. One excite is also equally important as the persistence now. And T is temporal factor. So P into R as T. So in that site is important and how long it is. So with that you can.
Yes, sir. Timing it usually lasts more than 2 minutes and doesn't extend beyond 15 to 20 minutes, which is typical. And if it is increasing with exertion, especially after food intake.
What are the relief factors that I am using?
Relief factors during resting positions are standing during resting position, and also with the use of sublingual sorbitrate or nitroglycerin.
No, that is not now. Because they see what angina two projects. One is epicardial and second macros. So macros will nothing to do with macros. So it is typical angina, not relief capital. So think of macros angina. So macros angina doesn't relieve of the macros.
And what is linked to angina?
Linked angina, sir, when the patient yes.
So what happens?
After taking the food, because of the splanchnic vasodilation and increase in the oxygen demand for the splanchnic circulation, patient will have angina.
Which artery is likely to be more linked to angina?
Left systems are predominantly left circumflex or triple vessel, multi-vessel disease. Multi-vessel disease predominantly.
So postponed.
Yes.
Have to involve the
Okay. Okay, from history or you have the components.
Yes. Yes, sir. He has 4 symptoms predominantly, which are.
That all developed one time, 2 months.
Yes.
Everything developed since 2 months.
Yes, sir. Which is a relatively insidious onset, but recent onset. So it is not acute onset. Sir. No acute symptoms which made him hospitalized, but it is relatively recent onset. Sir.
Yeah. So what is the possible diagnosis?
Sir, possible diagnosis could be acute valvular regurgitation. Yes.
Where being active?
It can be a previous compensated disease which might have precipitated because of the precipitating factor, or it can be.
Then that is activation, active onset, activation.
Yes.
Okay, what are you saying?
You started saying something. You what?
Sir, in form of volume overload situation, sir. It predominantly aortic regurgitation or mitral regurgitation or ruptured sinus of Valsalva.
Mental is not a big system.
But yeah, exactly.
Yes, sir.
The volume overload, why suddenly chest pain?
Yes, sir.
Here, okay, here we can activate. But one MRI system.
Sir, mixed valvular disease like associated LVOT obstruction in the form of aortic stenosis is a possibility. Or
Outpatient patient develops severe MR, what the great patient. Patient of known outpatient, develop active MR, what the great patient. Severe pulmonary MR.
yes, sir.
And cardiac stuff.
Yes. Yes, sir.
Okay, so these three conditions you put. Yeah, MR,
Yes. There is no a significant history of PND or orthopnea, sir. Right-sided obstructive lesions in the form of pulmonary stenosis is also possible, sir.
Coronary disease per se.
Sir,
Coronary disease per se. Coronary disease only angina pectoris. Ischemic disease, coronary disease.
sir, exertional palpitations suggestive of volume or palpitations unlikely in
Because during ischemia, MR develops. MR ischemia.
yes. Possible. Acute chronic stable coronary artery disease with an acute precipitation can be possible.
How old is the patient?
Patient is 37 years old, sir.
So he has no risk,
No risk.
So let's see the parasoli of the air and MR, I don't think MR. MR won't put standard. Only the patient had first pattern to us. That angina like symptoms are not typical angina does not. So why MR doesn't develop angina? AR can develop angina.
Sir, MR in AR, because of increase in LVEDP, there will be decreased coronary perfusion pressure and also there will be severe eccentric hypertrophy where the demand of the LV will be increased. Whereas in MR,
No. What
the
is
LVEDP
important one? Gastric pressure low and ED increases. So
coronary perfusion pressure
perfusion
decreases in AR, whereas it is not so in MR, where the LVEDP is not increased until late stages, only during LV dysfunction. And there is a
end systole was stress more in there or MR?
Sir,
End systole was stress more in there or MR?
sir, end system.
Was
Wall stress, in systolic wall
Wall
stress.
stress is more in AR.
That is more important, no?
Yes.
Wall stress, high rate, is compared with their three determinants of
Yes.
mechanical oxygen demand. So wall stress not increasing case of MR. So that is MR case won't develop angina pectoris.
Yes. Past history.
No, go to patient.
Anything relevant?
No.
Okay, then leave it, sir.
Okay, patient has got ROC here, somebody from ROC. What passes to look for?
Past history of associated congenital heart disease like VSD is a possibility. Vertical circulation. Sir, treatment history. He is on penicillin prophylaxis. He is on medication since 2 months. No history of any previous procedures. No history of any previous hospitalizations. On general examination, patient is moderately built, well nourished, height is 165 centimeters, weight is 67 kg, BMI is 24.6. Upper segment and lower segment ratio is around 1:7. Arm span is 170. No pallor, no interest, no cyanosis, no clubbing and no lymphadenopathy. No peripheral signs of premature atherosclerosis, infective endocarditis or peripheral signs of AR. No evidence of any thyroid goiter. No dental caries.
Direct, no?
Goiter, sir. Goiter.
Okay.
Sir, CVS vitals. Pulse 96 beats per minute. It is regular. It is normal volume and normal condition of the vessel. All peripheral pulses are palpable. No radial and no radiofemoral delay. Blood pressure. There is no significant difference between right upper limb and right and left upper limb. That is both are 110/70. And the lower limb.
What is the diacritic pulse?
Sir, normal pulse is.
What is diacritic pulse?
Dichrotic pulse is seen in severe LV dysfunction. It is 2 peaks which are seen. One peak is seen in the systole and the other peak is seen in the diastole.
Are you sure?
Yes.
Answer. Then,
It is
where
seen,
to get which actually seen?
sir, it is seen in severe LV
No,
dysfunction.
so secondary. It's seen carotid or femoral or.
It is seen in carotid. Sir. Carotid.
They are not carotid, they are carotid. Diacritic pulse you won't get in carotid.
Because of the peripheral reflection. So, right and left lower limb, 120 mmHg. Respiratory rate 18 breaths per minute. Thoracoabdominal tight. No use of aspiratory muscles of respiration. JVP is normal, not raised in sitting position. Prominent A wave. Normal variation with the respiration. Heterojugular reflux is negative. Cardiovascular examination proper. Inspection and palpation. Chest is symmetrical. Trachea central. No evidence of precordial bulge. No scars and sinuses. Apical impulse or apex fluid is visible in the 6th intercostal space. 2 centimeters lateral to the mid-lateral line, occupying 1 intercostal space. The duration is more than 2/3 of the systole, which is heaving in nature. No apicocarotid delay. Bilateral supraclavicular pulsations are seen. No evidence of thrill or palpable heart sounds.
So that's the person doing.
Sir, increased.
This is what person because what? Clavicular system or separate clavicular person doing.
Yes, sir.
What is the structure?
Brachiocephalic subclavian, yes, brachiocephalic, innominate. Percussion, left heart border corresponds to the apex, right heart border is retrosternal, left second intercostal space is resonant. Auscultation,
No, hold on. Stop. Before auscultation, always I will stop you. Now, where are we? Hemodynamically, what have we found out so far?
sir, hemodynamically, he is having a heaving type of apex, which is deviated down and out.
Heating means what? Heating means what? It is pressure over volume or what?
So it is a pressure overload. Yes. The pressure overload LV apex, sir. So patient is having LVOT obstruction, sir. And associated LV dysfunction or associated lesion in the form of mitral regurgitation or aortic regurgitation.
You told LVOT obstruction, but you are telling supraclavicular pulsation there.
Yes.
You said that the pulse is normal in volume and character. Your blood pressure of 110/70 is just marginally low. Your pulse pressure is 40. There is nothing in the periphery which is favoring the ventricular outflow tract obstruction. And you said there is a suprasternal pulsation which is prominent. Supraclavicular pulsation is prominent. So what else is see, when I ask you what we are, where we are hemodynamically, you have to put everything together.
Yes, sir. Sir, I have LVOT obstruction with LV dysfunction is a possibility.
LVOT person has got LV obstruction with LV dysfunction is possible what? Low volume, high volume or normal volume?
Low one.
So then, that is
Can a mark of
MR with LV dysfunction can cause yes.
what you get this is high volume pulse.
No, sir.
MR itself has volume pulse.
Now you said all these peripheral pulses are right. How is the dorsal pedis?
Dorsal pedis is brisk, sir.
Brisk. Now if you had every outflow tract obstruction with every dysfunction, would you expect dorsal pedis to be brisk?
No, sir.
Then
Dorsal space actually very difficult because go down. So dorsal space
no, but it's very easily and here according to verified. So my question is, if there is outflow tract obstruction with superadded every dysfunction, what will happen to stroke volume?
Stroke volume will be decreased.
Will be decreased. So you would expect pulse volume, especially in the periphery, to come down, right? But it's not happening. So then,
Associated lesions in the form of aortic regurgitation is a possibility. Yes, sir. Pulse pressure is relatively narrow, sir, but aortic regurgitation is a possibility.
the outward disease
why is the airway prominent on the JVT?
Sir, it is because of the
Is it prominent or normal?
A is prominent.
Huh?
Airway is prominent.
These are prominent.
It is because of increase in RVD, because of left-sided heart disease causing the pulmonary hypertension.
You have got your outward disease, but outer stomach says, what other stomach disease?
Associated mitral valve disease
Somebody left happen to be there. Are we compliant with this?
because of reverse Benim also reverse Benim
Harder burning.
because of the Benim.
No, septum the part right also.
Yes,
Also,
yes, sir. Because of the Benim airway can be
burning, burning also. You may not watch now. But septum is a hypertrophic, so part fragmented. So are we compliant with this? You can from everything.
yes.
You know what is atrial burning?
Atrial burning.
these conditions you get atrial body.
The septum has to bulge just like the ideal. The septum has to bulge.
Yes, you remains member of it.
So it can take.
Sugar remains. So what our mind is that you are looking at the updates and
Is there a single apical is there a single impulse palpation in the apex or no? Because you're saying it's heaving.
Yes.
So there is pressure overload.
Yes.
So is there an S4 or an equivalent of an S4, palpable equivalent of an S4?
No, sir, I could
No.
not.
Okay, auscultation.
Auscultation, S1 is loud, S2 is single, lightly fused and loud, sir. And S3 is absent, S4 is absent, opening snap is present.
S1 is loud.
Yes,
Huh? And S2 is single.
probably fused, yes, sir, and it is loud.
No, why is it fused?
Because of fused, S2 is single.
No, fused single I can understand. A2 and B2 are simultaneous. But
or it is absent. It is very short.
Sir, you can, in this case, in my case, sir, it is probably because of the LVOT obstruction now.
What is that? This is out of all we can mobile. No mobile will do also.
I'm accepting your statement that you are saying both A2 and B2 are occurring simultaneously throughout all phases of the respiratory cycle.
Yes.
My question is, what is the hemodynamic basis for that occurrence?
Sir, it is because of LVOT obstruction, because of which there is increased ejection time, which will cause the A2 to move towards the P2.
So if we were to leave him alone after some time, it will become paradoxical, is what you're saying.
Yes.
A2 will get further delayed. He is on the way to becoming a paradoxical.
No, no. What is the clinical how to say this and problem? You say upload delay not there.
Yes, sir.
Second, you are saying the normal cost character.
Yes.
So clinical there is nothing to say there is this problem.
Yes, because of the pulmonary hypertension, the P2 can also come close to the A2 because of the pulmonary hypertension.
Still, I will explain why that basic variation is missing. See, normally the A2, B2, there is a phasic movement, isn't it? There is a variation with the respiration.
Yes.
So when you say there is single, it could be because it's a single aortic component or a pulmonary component. You clearly said it is because it is fused. Now, if it is fused, why is it fused? That was, I think, the question.
You should have mentioned fuse. Understand?
Exactly. You shouldn't have said it's fused. Single, it's a finding.
Single and loud.
But then our this question, what is in the apex, how many stamps are here?
Sir?
In the apex, how many stamps are here?
FX, sir. I could hear three FX 2 sounds, sir. Slightly medial 3 sounds. Opening snap also I could use.
Okay, second sound is in the apex.
Yes, sir. This out.
That could be
P2.
B2. No, one second. No. Now you said there are at least two sounds heard at the apex.
Yes.
One is the first start sound, which is loud. The second, I presume, is some component of the second art sound.
Yes.
Right. So normally, which one would you expect to hear in the
Normally
apex?
A2 I would expect.
But here you're saying it's B2.
Sir. Because of,
very soft because of the environment.
No, one sec. You said the apex is 6 space 2 centimeters lateral to the mid-lateral line leaving.
Yes.
Left ventricular.
Yes.
Huh?
yes, sir.
So then how can it be P2 at the apex?
Associated pulmonary hypertension is there, sir. We can hear.
But what happened to with an enlarged left ventricle? You're saying the P2 is so loud that it is heard at the apex, but A2 is not heard at the apex.
Because it is a single S2, sir. I'm not able to reliably say which is heard at the apex.
But it's actually it's not like the
A2 is like this.
Likely. So that means A2 exists.
Yes.
A2 hasn't disappeared.
Yes.
Okay, so then what is the single sound which you hear in the left second space? We know that A2 is there,
Yes.
logically.
Yes.
So is either P2 missing or is it your earlier statement that A2 and B2 are simultaneous throughout the cardiac cycle
So
or the respiratory cycle.
so the intensity of single sound which is heard in the left second space is higher compared.
Or loudness people is damping the echo so that not able to appreciate it. Something happens like this. Acoustically damping the echo is a loud
Sound
echo.
which I can hear is louder in the second space compared to the apex.
No, but nobody said the A2 has to be heard as loudly at the apex as it is heard in the left second space. It is only that A2 is normally heard at the apex.
Because it is a single second half sound, it is not clearly differentiate whether it is A2 or B2.
Okay, fine, go on.
Sorry.
We still have to do the numbers and.
Yes. There is a pan-systolic murmur at apex.
You mentioned one opening snap.
Yes. There is an opening snap which is heard in the left fourth intercostal space, which is best heard with the diaphragm of the stethoscope, which is sharp in
Even
tone.
diaphragm and they don't open some heart.
No.
They start
A2OS interval is long, not short. There is a pan-systolic murmur at the apex, which is soft, blowing, and high pitch, grade 3, which is S1 coinciding, plateauing configuration, radiating to the left axilla till the anterior axillary line. Soft, blowing, high pitch, which is grade 3, S1 coinciding, plateau in configuration, radiating to left axilla till the anterior axillary line.
S1 coinciding with
Pan-systolic, sir. Increased with the squatting and hand grip, decreased with the standing and valsalva strains. There is a mid-diastolic murmur at the apex, which is grade 2. I could not hear any pre-systolic accentuation, which is increased after exertion. Best head in the left recumbent position with the bell of the stethoscope. Yes, sir, sharp.
Okay, just a word of caution. At some stage, we were thinking about left ventricular outflow tract obstruction with LV dysfunction. Under that circumstances, please do not make the patient exert. See, whether your suspicion was right or wrong is a different story, but if you have that among your diagnostic possibilities, do not try to bring out how good the murmur is by exerting the patient. It doesn't matter. Okay.
There is ejection systolic murmur head in the right second intercostal space, which is grade 3, which is harsh.
I am not clear. What is something is coming to your dashboard or it is finishing before the
Finishing before mid systole,
Yes, sir.
not reaching the
Yes, sir.
second sound.
this one? Sanjay, no?
It is starting after sometimes. It is not. It is in the mid diastole, not from the early diastole.
So now the opening snap is wide.
Yes.
Engine occurring. Then after that there is some space. That time also for this one.
Yes, sir.
Okay.
There is ejection systolic murmur in the right second intercostal space, which is grade 3, harsh in quality, increase to decrease in the configuration. Late peaking, radiating equally to both carotids, which is increasing with squatting, decreasing with standing and valsalva strain.
Why do you like this? Why do you like this? What happened? Why do you like this?
Looks like a multivariate disease.
Yes.
No need to do all this dynamic software. Talk about the murmur, talk about the murmur, the peaking, the pitch. That's enough. You don't have to again do Valsalva and to do squatting. Here only you are here. Again, right into the
Yes. Other system examination.
Before that, I have to get clarity from that opening snap or ST.
Sir, opening snap.
Because the way of presenting mostly ST.
Yes.
It's not a short evidence, you know.
Yes.
Short evidence, there is opening snap. Why not ST?
Sir, it is decrease, no variation with the postures. I mean, squatting and standing. It is equally heard and it is sharp in quality, unlike S3. Sir. And there is no palpable.
Please don't, what is the S1 intensity here?
Loud. Sir.
Loud.
Yes.
So consumer will get some loud. That happens once it's matter for us.
It is not soft, sir.
So we are getting Indian and South Indian receivable function.
Yes.
And A2 function, the gap is quite wide. And we are getting a system of get taking number.
Yes, sir. Ejection system is not right. Sir.
What will the erotic upstroke like?
Sir, carotid upstroke is normal, sir.
So how did you get to the
Normal.
normal? How did you get to the normal?
Sir?
How did you get to the normal obstructive characteristics?
Yes, sir. Pulse I could feel, sir.
So
No.
you explain this, hemodynamics you have explained this. You late to the normal and the normal character of obstructive.
Yes.
That too, the severe MR, there is a severe MR, we are getting a check and get to the normal. Severe MR or MR is actually augmented here because of power of the disease. But does it happen like this?
Yes, sir. AS can aggravate the intensity of the MR, increase the oscillatory signs of mitral regurgitation, and decrease the oscillatory signs of mitral stenosis.
So it was also MR of the disease hospital can
Yes, sir. MS can. Yes, sir. MR can have a low flow, low gradient situation in AS.
So these are the things, so there is actually there is not, there is no correlation behind and
Okay, so you told us about an ejection system, anything else?
No, sir.
Other systems?
Other systems, normal.
Normal.
there is no
Okay.
reason, no reason.
No reading.
But you have done that.
I have done, sir.
Diagnosis?
So diagnosis is acquired heart disease.
Your course test you have not at all. Your mobile phone. You want to take water to give the sort. Have a course test.
Yes. Acquired heart disease, rheumatic etiology, multivalvular heart disease in the form of severe mitral regurgitation, moderate MS and moderate AS. With the moderate P pulmonary arterial hypertension, mild pulmonary venous hypertension in sinus rhythm, not in congestive heart failure.
Severe MR.
So severe MR, moderate MS, moderate AS, NYHA class 2.
No, no.
Moderate pulmonary arterial hypertension, mild pulmonary venous hypertension. Sinus rhythm, sir, no evidence of infective hepatitis, not in congestive heart failure.
How can the mild pH goes to moderate pH?
Sir, he has a class 2, NYHA class 2 symptoms.
It was usually kept deliberately because of that. Morning also says the same thing. That's what they are saying in the morning. We kept a valvular in the end for all those who missed in the morning. I think this concept was again and again told. Mild PV and severe PA.
Transpulmonary gradient.
See, his aortic systolic pressure is 110.
Yes.
Right? You said moderate aortic stenosis, there is no aortic regurgitation. So roughly ballpark, what figure are you thinking about gradient across the aortic valve?
Give me some number. Gradient across mitral, aortic valve. Sir, there is no presence of apical and no escort to correlate for gradient. JVP is not raised, sir.
What is GCP have in terms of heart of second action? In place of severe MR, heart of second action.
It becomes a wide split, sir.
And
Wide
here
gradient split. Here it is narrow, sir.
The other one is almost single. So then how can you say AC is moderate? People like not to say severe second action single or paradoxical. Right now more than 70% of the reactors are zero.
Yes, sir.
Now how to explain that?
Presence of single split correlates with 70 millimeters of mercury of AS gradient, sir. LVOT gradient. But
You are in moderate AS here. That's the each question.
I'll come back. Just roughly, what do you think is the gradient across the aortic valve?
sir, moderate AS mean will be less than 40, sir. between 30 to 40.
What mean gradient?
Systolic peak gradient will be 70 to 60 to 70.
Dr. Lakshmi showed some traces of mean gradient, no?
Yes.
Huh? So I mean, across the aortic valve and aortic stenosis, we are only talking about systole. Huh? So mean gradient, how much are you saying?
Mean gradient less than 40.
Less than 40. And you're calling it moderate aortic stenosis.
Yes.
Huh? Okay, for the house, do you agree with him? Wake up everybody, come on. Answer has to be yes or no. How many people say yes, how many people say no? Prayag, I hope you won't mind my. Huh? He says mean gradient across the aortic valve is 40 millimeters of mercury. No, less than 40 can be anything from 0 to 39.
So 40 means severe age, no? Less than 40, how much? So classification of what severe age according to
Sir, mean less than 20 is mild, 20 to 40 is moderate.
20 or 25, yeah?
20,
20 or 25?
20 plus. 20 to 40, sir, less than 20, 20 to 40, more than 40.
You want
Mean
to
gradient.
qualify this statement?
Yes, sir.
Mild is less than 20, moderate is 20 to 40, severe is more than 40. Finish the sentence. Provided
Provided LV in at optimal loading conditions like normal blood pressure and LV function should be normal. In the presence of normal LV function.
If the brain not function, in the absence of personal reason.
Yes, sir.
And in the absence of and hypertension.
Yes.
Hypertension is usually underestimated.
Okay, so what is the peak LV systolic pressure in this patient?
Sir, to be less than 60, sir.
Now, what is blood pressure now?
Peak
pressure is,
peak
110.
systolic blood pressure in the aorta is 110.
110.
There is moderate aortic stenosis. What is the peak LV systolic left ventricular systolic pressure?
160.
160. There is severe mitral regurgitation according to
Yes,
you.
sir.
What will the LA pressure be?
PVH, sir, PVH mild to moderate PVH correlates with LA
No, no,
pressure.
no, no.
Don't say right PVH. You're
Number
saying
nine.
the left ventricular pressure in systole that is 160.
Yes.
The mitral valve is wide open in systole, which it should not be. What happens to left atrial pressure? You're following the argument.
Pressure will increase, sir.
You increase substantially, right?
Yes.
Then how can you have high PVH?
Yes.
The moment you put these two lesions together, mitral regurgitation, significant, and aortic stenosis or even more than mild degree, left atrial pressure has to be very high, right?
Yes.
You follow? So you cannot have a situation like that and then say mild PVH.
And the moderate severe case.
Yeah, I mean that is a subsequent inference that I am saying. Huh?
Yes.
Only 6 minutes. Any different, no differential. So what do you want now? ECG X-ray before echo. Okay, ECG.
Normal standardization, sir, 12 lead ECG, sinus rhythm, sir. Heart rate is around 100 beats per minute, and the axis is left axis, sir.
Approximate axis. AVF
AVF is biaxial. It will be exactly minus 10, 0. Zero to minus 10. There is evidence of LA enlargement in the form of increased internal force in V1. Lead to I could not see the notching because of baseline artifacts.
Let's see that defects in the knee or
There is notching V3.
Thing is, there is any enlargement there?
LA enlargement is present. No evidence of LV enlargement. No. No evidence of LV enlargement according to ECG criteria, and no evidence of RVH sinus signature 1:1 AV connection.
Okay, so is the ECG consistent?
Where is Sulu sir? We stop with them. Why didn't
Severe moderate AS LA
Any
enlargement is because of MR, mitral regurgitation. Mitral regurgitation and severe AS, no features condition of severe aortic stenosis, like LVH and LVH pain are not there.
You have a low first start sound, you have an opening snap, and you have an MDM, which according to you is short everything. You still want to maintain that the mitral stenosis is only mild
Yes,
or moderate before.
yes sir. But it can be underestimated because of the regular obstruction, the form of aortic stenosis, which will cause the increase in duration of ATOS and increase the
It can be overestimated because of the MR.
Yes. X-ray chest behavior, very exposed, very centralized. Trachea is in the central, no bony or soft, no bony abnormalities. It is a levocardia, situs solitus, LV type of apex. There is a LA enlargement is seen in the form of double density on the right heart border, and there is a splaying of carina.
I don't think.
This one, sir. Ascending aorta, I could see prominent knuckles, unfolding of arch. There is pulmonary venous hypertension in the form of capillarization and faintly visible curly V lines, grade 2 PBH. Pulmonary arteries are not dilated. Sir, it is associated with if there is aortic regurgitation, but in my case I could not find.
The thing is, not there, so MR, therefore, after that, not lies. It's not rheumatic MR, maybe. There no enlargement there.
Yes, sir.
Put back of the
Sir, MR I could appreciate the radiant axilla. And he has history of penicillin prophylaxis.
Be very careful with this history of penicillin prophylaxis. A lot of people in our country get penicillin prophylaxis for lesions which are non-rheumatic. I mean, because somebody erroneously thinks they are rheumatic. So don't think that somebody is getting penicillin prophylaxis means that they are rheumatic.
This parasternal long axis view, which is showing dilated left atrium. LV systolic function is normal. Aorta is not dilated, RVOT is not dilated. There is mitral regurgitation, which is amounting to mild to moderate, sir. And there is the mobility of the aortic valve is decreased. There is a forward turbulence in the aortic valve, and also there is a mild aortic regurgitation, sir. And there is also the mobility of the PML is restricted. There is a doming of the AML. Thickened leaflets are seen. No visible vegetations or clot As descending aorta is seen posteriorly. No evidence of any pericardial effusion. This is apical four-chamber view, which is showing dilated left atrium. There is a echo dropout in the infraatrial septum. The LV function is normal. There is a forward turbulence across the mitral valve, and there is a eccentric mitral regurgitation which is posteriorly directed, amounting to moderate mitral regurgitation.
So mitral valve pressing at downward. And Dr. What do you think the question of severe stenosis? Dr. Rice, what is severe stenosis? Because that is a bracket.
Yes.
So what do you think? Severe or mild?
Severe mitral stenosis. This is a short axis across mitral valve. There is no regional valve motion abnormality. There is thickened mitral leaflets and there is looks like fibrotic valves. Commissures. Commissures, lateral commissure is fused. Middle commissure is partly fused. No calcification in the commissures. Fishbone shaped opening. Yes.
Okay.
This is continuous wave Doppler across the continuous wave Doppler across the LVOT, which is showing a mean gradient of 48 and a peak gradient of 64. Parabolic in nature suggests a fixed outward attraction. Yes. Yes, the aortic stenosis is severe and mitral stenosis is also severe. Both are severe. Sir, since 2 months only is symptomatic. No past history. Any regular symptoms, no history of rheumatic fever. Sir, we used to do double valve. Sir, we can do aortic valve replacement along with open mitral valve. Because MR is not severe, we can do open mitral valve. And Maze tricuspid is also not dilated. Sir.
You want to put how do you want to diagnostic and you will see because you will definitely matter replacement sometime.
Yes.
So let him
Right time.
give by time and let him also without actually.
Sir, replacing the mitral valve, sir.
No, matter not matter there. Put a backup and
Bioprosthetic aortic valve and mitral valve repair.
another can you can use it for matter of placement.
Yes, sir. That can be done. If a patient is accepting the risk of review surgery as well as
Even surgery, yes, even with
Yes.
OMP, yes, it's still
yes.
risk of being slightly controversial. Why not balloon the aortic valve?
Sir, the results of romantic aortic valve. Sir, the results of balloon dilatation only during a balloon dilatation in rheumatic as well as calcified degenerative areas are not good, sir. They have repeated re-interventions and also.
According to whom?
Sir,
The results of balloon aortic valvuloplasty in calcified and degenerative aortic stenosis are pathetic. That is well accepted. Okay. Huh? But the pathology in rheumatic aortic stenosis is different. It is capsular fusion. We couldn't see too much calcium on that aortic valve. We have some experience. Jipmer, I think Dr. Ajit has published something on balloon dilatation of rheumatic aortic stenosis, where at least same argument, you buy some time. See, all said and done, valve replacement surgery is not benign. Okay, so you can buy some time, do a balloon with the mitral valve, and relieve both the stenosis, and he will definitely require surgery later.
yes. There is no significant cancer.
How do you have to not delivery is controlled in the case of only congenital artery stenosis is fine, but whatever degenerative 6 months after complication also.
Okay, now, right, 2 minutes.
So we can summarize. Yes, sure.
Okay, no, now earlier something was said about how in the presence of a normal cardiac output, mild, less than 20 mean gradient is mild and 20 to 40 is moderate, right? Huh? Does everyone agree with that statement? Yes, no?
Yes.
Yes. What is Haki's formula? Haki. Somebody,
Yeah, Silver, yeah,
somebody said yeah. Here. No, let everybody hear what you're saying.
Cardiac output divided by 44.3 into.
No, Haki.
Simplified version.
Not Gaussian. Okay, cardiac output by under root of the mean gradient. Mean gradient, Haki actually said you use is whatever gradient you like and just take an under root. Okay. No. Cardiac output by under root of the gradient. Now, all of you are saying, and that 20 to 40 represents moderate aortic stenosis. I am saying the mean gradient is 36, under root is 6. What cardiac output do you need to have moderate aortic stenosis? The denominator is 6. To get an aortic valve area of 1 centimeter, you need a cardiac output of 6 liters. Okay. You think our patients have a cardiac output of 6 liters? I'll give you a lower mean gradient, 25. Under root is 5. In the presence of cardiac output of 5 liters per minute, aortic valve area will be 1. That is mild, moderate, severe, what? So, this belief that 20 to 40 mean gradient in the presence of normal cardiac output is moderate is, I am afraid, at least I cannot understand the logic behind that. Even if it is written in a book, it to me doesn't make sense mathematically. Any mean gradient above 20, you need a very good cardiac output to have a decent valve area. Simple logic. Okay. So the statement that a mean gradient across the aortic valve of 25 or 30 or 35 is not really, the patient is not really in trouble, especially with our small built, relatively distinct patients. I don't see the logic of it.
Summarize the case.
Normal or there is no normal. Probably say normal or they were getting already fasting. And you must be wrong in there. And you told they taking one more, there is no correlation out there. And finally, you nodded with these with the mild disease. So, these things are not correlated with each other. Otherwise, it is good. And also,
So one question that has come is with Garavati, you will see in severe the calcific case. This is not calcific. Somebody asked that. Why do we say that this is not?
no. That is different. That is note. Musical note. See, what LV is coming assessed. Any kind of LV event can have in the effect. See,
Correct.
because the LV, you can get loud speed in the effect.
Yes.
LV, so LV,
Because not in the severe. Not on that severity. Basically, they have to,
That answers the question.
it can be heard.
That was the only question for today. So thank you. I thank all the speakers. Sir, can you just give a small token of I also request sir to give a token of our love to Dr. Vijay Sai sir. He's been with us all through the day. Sir is also, as I said, one of our earliest students from Puttaparthi and also the head of department at Vaidi. Sir will also join us tomorrow. So Nitin and sir. That's it, please. So the whole gamut of cases today was actually decided in such a way that we tried to cover today and tomorrow the whole gamut of cyanotic heart disease. That is, we tried to. Thank you so much, sir. Try to cover the Eisenmenger part, admixture part, transposition physiology, classic top physiology. That is all that it is, and we will continue again tomorrow. Some cases we could not get, some clinical cases, so we tried to supplement one case like that, which will be a very short case, will not take too much time considering that we are late. Dr. Subramaniam, our junior consultant, will actually present it. This is one of the cases that's also asked quite frequently in exams. We'll go for about 15 minutes, then we will stop for the day. Thank you. So there's one clinical case like a case discussion.